conference back in February of this year. It was in Honolulu, Hawaii, and this is the beach that I spent my free days on. So. The first thing I'm going to talk about, I actually have 3 topics. I have one about new evidence on how to better treat subarachnoid patients. A second topic that kind of talks about when our patients leave the hospital and some of the challenges they face. And then a study that showed the pros and cons of extending the TPA window to 9 hours. Now it won't go. Okay. So this is some of the things we already know about our subarachnoid patients and how to treat them. The most important thing is to perfuse and oxygenate the brain. You really want to avoid hypotension and keep the map above. Oh, but this is not the right slide. Hold on. It's not showing the same slide up here, Haley, that it is up there. Okay, there we go. You need to treat the initial subarachnoid bleed as a TBI or cardiac arrest because it is just as important and critical as those. Fluid resuscitation is very important, but you want to make sure that the patient is going to be fluid responsive. If the cardiac index is not increasing with the stroke volume by 10 to 15%, then the patient is not fluid responsive, and no matter how much you bolus them, it's not going to help. They also showed that some stress-induced cardiomyopathy was seen in about 13 to 28% of subarachnoid patients, and that's something that we may not think about in our unit as much, but it does really affect hemodynamic autoregulation. And they also looked into some of our grade 4 and 5 subarachnoid patients. These are patients who are either doing all or nothing, and it's really important to tell the family that when they come on the unit, when they're admitted. Like, they need to make a decision, are we going to actually treat this, or should we move to something like palliative care, because anything in between is really not going to help. And they found that after day 5 or 7, if the exam is still poor, there's really no point in continuing medical intervention or surgical intervention. So it's important to discuss that with your family member when they come in, just so that they're prepared for how the treatment may progress. It's nice to get an MRI on admission, but it's not always feasible. Your doctor may put a stat MRI, but we know that's not actually a thing. Another term that they brought up during the presentation, which I thought was really interesting, was the early brain injury. And this is a massive spike massive spike in ICP with the first initial bleed. These are patients that come in unresponsive, not your patients that are walkie-talkie. The best way to treat these patients are hypertension, hypervolemia, and hemodilution. So you're going to use pressors, you're going to use your Livonio. You're going to bolus them. You want to achieve for a hemocrit of 30. And you want to hemodilute them because decreasing the viscosity and facilitating cerebral blood flow is really going to help perfuse the brain. But of course, we know that there are complications with this, especially with our patients that come in unsecured. You don't want to increase their blood pressure too much, so you have to make sure that they're going to be clipped or coiled first. And they're going to need an EVD as well, because if you're going to bolus them, they're going to have some way to drain that excess CSF. And if you're hemodiluting them, their electrolytes are going to be all out of whack, so you really have to keep on top of their BMPs and replace electrolytes as necessary. Some of the new evidence on how to treat vasospasms and avoid DCIs. We know that our window is within the 4 to 14 days. We already use our nematop, which we all know really well. These are 3 different studies that they did with different treatments. I'm not going to go into exactly the population and how they chose, because I don't have time for that. But they did dual antiplatelet therapy. Half the patients were coiled and half were clipped. They showed that it decreased vasospasms and ischemia, but it didn't actually improve their functional outcome once they left the hospital. They did a study with heparin IV. It showed better cognitive outcomes after 3 months, but the final experiment results are still in progress for that. And they also showed a study with using Decadron, and which also improved functional outcome, but didn't affect their risk of DCIs. A couple of things that are really important with their subarachnoid patients is that you can utilize is the ultrasound. We all know which doctor really likes to use the ultrasound. It's non-invasive, it's less expensive, and it can be interpreted by the physician at bedside, which is useful, but it's also kind of subjective. It's not going to tell you exactly what's going on, but it's nice to use, you know, right then and there when you need to do some evaluation. You're able to answer clinical questions. Are they fluid responsive? And it's also not continuous, so it's not going to really predict their outcomes very well. And we also know personalized BP management is very important. The longer that your patient is outside of their goal window, the worse their outcome is going to be, because their brain is not perfusing effectively as it should. Day 7 is when it's most important to keep a close eye on their goals, because that's when their DCI is most likely to happen. And we also know that it's especially crucial during the vasospasm window of day 3 to 21. This isn't my second topic. This was more nursing based than some of the other presentations. It really interviewed the informal caregivers. So we're formal caregivers because we get paid to treat patients. These your informal caregivers are your families, your significant others. They're not going to be paid. So we don't really take them into account because we see our patients in the highly acute phase. That's kind of like the last thing on our mind when, you know, we're thinking about after. But it's actually really important because if they're not effectively educated on what to expect with their family member, then they're going to have worse outcomes no matter what we do with them. A lot of the patients come in, or the family members come in fully committed. They're like, yes, I'm going to take care of my son or daughter, mom or dad, but they don't really understand what that entails. They don't understand the resources, the money, the time they're going to need to dedicate. Or they may think that it's just going to last maybe a couple months and then they'll be back to their normal daily living, but we know that that's not how it's going to happen. One of the quotes I really liked, I already have 3 children, I don't need another one. So they talked about their mom and dad acting like children in public and embarrassing them. So that's something that they may not think about when they come into our unit. Barriers, they become more difficult because the patient's not progressing like they hoped. We see that all the time. Family members think that, oh, mom and dad will be back to normal, or how long do you think they're going to be like this? I get that question a lot. And they don't really realize that it can be indefinite. There's physical strain on the caregivers, emotional strain, and financial strain. Obviously, most of our patients are total care, and when they go home or to rehab, they're still total care. And if, little 88-year-old grandpa is taking care of his wife, like how effectively can he really do that? And or the son and daughter may have their diseases of their own that they're dealing with, and they don't have anyone else to help them. There's obviously emotional strain. Every caregiver that they interviewed showed a decreased quality of life after 15 to 22 months. They feel like their social and leisure time kind of went to the back burner. And obviously there's financial strain. If they live out in the boonies, they have to drive, or they have to pay for special beds or resources, stuff that they don't really think of this when they come onto the neuro ICU. And I liked how they compared it to dementia, because strokes are very sudden, whereas caregivers with dementia are sometimes able to handle it better because it's more gradual. They have time to prepare. So a good way to combat some of these problems is doing caregiver assessment on day 1. I know we don't really like this, or we don't really like to think of the family as like our patient too, but it can really help prepare them for what's to come with their family member. Assess their physical ability. Is their 88-year-old grandpa going to be the primary caregiver? Maybe ask if there's other family that can help out and take care of him. Assess their financial ability, you know, get case management and social workers involved as soon as possible. And it's most important to assess their willingness and understanding of the situation. This was a tool that one of the presenters developed. There's 25 different questions that you can ask them. I wasn't going to list all of them, but some of the good ones were, how much do you understand about the stroke, how the stroke will affect your lives over the 6 months? How much do you understand about what the stroke survivor will need with personal care, like bathing, toileting, dressing, ambulating? These are things that your family member's probably not thinking of in the moment. And when they, after the initial like shock and phase, once you get them all settled, like just maybe ask them a few things like that. Like just prepare them for this is gonna be in for the long haul. And I liked the quote, a stroke is actually a family illness. So I know we already have a lot on our plates with everything we do, but RNs can actually have a huge role in educating our family members, because if we're not educating them, they're gonna turn to other sources for information, like the internet and family members, which can be good sources, but most of the time they're not trained and they're not actually educated in the matter. Caregivers said that these are their top 3 concerns with their loved ones: keeping them safe, managing physical and emotional stress, and making end-of-life decisions. And ideally, this should be discussed even before a stroke happens, but we know that that rarely ever happens. And the main goal behind the caregiver assessment is inform, activate, and collaborate. So inform about stroke care and ways to implement it, and then get feedback from the caregiver. So basically tell them about what to expect, tell them how they're gonna have to take care of their loved one, provide them with ways to do that, provide them with resources, direct them to social work, direct them to case management, and then get their feedback on what you just told them exactly, and make sure they ask questions. I mean, this is kind of like a controversial statement. Don't assume the patient's needs will always supersede the caregivers, because if the caregiver is not being taken care of, they're not able to take care of their loved one. Just like if we're not taking care of ourselves, we're not able to take care of patients. So you really should see the caregiver as a patient too. The caregivers that they interviewed said that they feel marginalized by the healthcare system. They feel like they're not really supported, they're abandoned, no one's really communicating with them effectively, they're not being provided the adequate resources that they need. So these are just things to take into consideration when you're admitting a new stroke patient. The system is not designed at the moment to address changing needs, unfortunately, so just doing what you can when they're admitted is really going to help them prepare for what's to come. And then discharge planning, we don't discharge all of our patients, but just counsel, even if they're just being transferred to IMC or the floor, just kind of provide them with some information on what to expect, counsel them and prepare them for discharge. Our caseworkers are great, so they usually are good about supplying lists of SNFs and assessing discharge plans to ensure that they're responsive to the patient's needs. Ideally, we could implement the thing like the 25 question tool system-wide, but I mean, there's still a lot of work to do that. That also means more documentation for us. One of the nurses that was in the lecture actually brought that up. That means that more documentation. How is this going to be billed? Like, if we're providing more services, that's just another, like basically another box that tick off in Epic. So there's definitely some barriers to implementing something like this. But making it standard practice would be ideal, and we would see much better functional outcomes with our stroke patients. And even though we see them in the acute phase, jumping in early and just providing some basic education on what to come can really make a huge difference. These are some more barriers that I talked about already. It's not reimbursable. Education and assessments aren't reimbursable. Time constraints, obviously. We already have so much on our plate as it is. We don't really think about sitting down with our family to talk to them and educate them about when they leave our unit. Documentation, it's gonna get missed, it's gonna get pushed aside. And then it's hard to follow up on our patients afterwards because of HIPAA. You can't go looking into their charts to see how they're doing after they leave us. This is my final topic. This was a study done, it's called the Extend trial, to see if there's any improvement in functional outcome by extending the TPA window to 9 hours. So this is some interesting background info on TPA. Some I knew, some I didn't. In 1990, there were no coach strokes, no stroke centers, no TPA. When TPA was first introduced, it was extremely controversial. It took 20 years for it to be accepted, and then, oh, great.
Because that's where we all wish we were. Yeah.
And then go to present, maybe? Present up there. Yeah. There we go. It took 20 years for TPA to be accepted and took 20 minutes for thrombectomy to be accepted, just to give you some feedback. I wanted to there's a really good episode of ER where it's like one of the early episodes where, yes. Yes. I tried to find the clip on YouTube, but I couldn't find it. But a patient comes in with stroke-like symptoms, and he wants to give TPA, but they fight over it because it's just so controversial. Like, you're going to kill him. He's going to bleed out. Like, they legitimately thought that it was better to just leave them as is than to risk bleeding out. Which is funny because, like, in our day, we give TPA all the time, and they don't really think twice about it, but maybe they should. They believed that there was nothing you could do for a stroke. After 1 minute, the brain was dead. So often they wouldn't even call an ambulance. One of the presenters said that she used to work in a home where if you saw a patient that was slumped over with weakness, you were just like, okay, well, they're like this now, and they didn't do anything for it at all. And NIH annual recertification was not necessary. So the idea behind the study was that extending the window to 9 hours would be helpful for our wake-up strokes. The patients that wake up with stroke-like symptoms. They went to bed okay, they felt fine, but then when they woke up, they had these symptoms. So their last known well is unknown, because did it happen right as they fell asleep? Did it happen right as they woke up? There's not really any way to tell. Some head imaging shows that symptoms had occurred shortly before awakening, so that's a little helpful. But this was really the idea behind the Extend trial. They felt that extending it to 9 hours would be really helpful in improving the functional outcome for these patients. So the standard timeline for treatment of acute stroke with thrombolysis is 4.5 hours right now. But studies show with CTP that the penumbra can actually exist for 24 hours after the initial infarction. And the penumbra is the area of brain that's not yet dead but has the potential to be dead, but it's still salvageable in that moment. We call it the at-risk brain. And it's damage immediately after the stroke, but due to decreased blood flow and lack of oxygen. But if it can be perfused within time, it can be salvaged. This is just some information on their recruitment of people for the study. 65% of the patients in the study had a wake-up stroke. 25% had a last known well of 6 to 9 hours. And then 113 received TPA and 112 received a placebo. And they showed that people who received TPA within 9 hours had significantly higher functional outcomes than those who received the placebo. This is just some stats based on some of the data. Long story short, basically it showed that there's still a lot of studying to be done with this. This in no way means that we're going to be doing those TPA sheets for like longer, or that we're going to be accepting more and more TPA patients. There's still a ton of studying that needs to be done. More studies need to be done, because it basically showed that the long-term functional outcome wasn't as great as what it is already with the 4.5 hours. Some side notes: the bleed risk was consistent with the usual bleed risk. Whether they got it at 4.5 hours or whether they got it at 9, their bleed risk was about the same. 6% of the TPA converted and only 1% of the placebos patients converted. And they weren't able to adequately recruit as many people as they wanted for their study because some of the doctors were sending them to thrombectomy. The takeaway behind this study is, like I said, more research is definitely required. In general, the longer you wait, the worse off your functional outcome is going to be. We already know that. If you notice that there's stroke-like symptoms, you need to call right away, regardless of their last known well, because it is still possible that they may be able to receive TPA. There's some stroke patients that have enough collateral flow that gives providers a longer time window to treat them. In general, you shouldn't just take the last known well as the only indicator whether to give TPA. You have to look at their whole presentation. You know, a 25-year-old may do better than an 80-year-old with TPA after 9 hours. You know, there's more to take into consideration than just the last known well. I think that's it. Any questions?
I kind of want to get a Hawaii.